What I'm about to share with you will challenge everything you believe about life, death, and the incredible resilience of human consciousness. 6 months ago, I was Dr. Sarah Mitchell, a 34-year-old emergency room physician working the night shift at Chicago General Hospital. I thought I understood the boundaries between life and death, having witnessed countless patients cross that threshold during my 8 years in emergency medicine. I never imagined that I would find myself on the other side of those boundaries, experiencing something that medical science still cannot fully explain. The pain started on a Tuesday morning, sharp and insistent in my lower right abdomen. As a physician, I recognized the symptoms immediately. Classic appendicitis, the pain, the nausea, the fever that was beginning to climb steadily upward. I had diagnosed appendicitis hundreds of times in my career, but experiencing it myself was entirely different. The pain was more intense than I had expected, radiating through my abdomen in waves that left me breathless and disoriented. I drove myself to the hospital where I worked, partly out of convenience and partly because I trusted my colleagues more than any strangers at an unfamiliar medical center. Rebecca Thompson, the chief of surgery, and a woman I had worked alongside for years, examined me in the emergency room with the professional detachment that all physicians maintain when treating their peers. Textbook appendicitis, she confirmed after reviewing my blood work and CT scan results. We need to get you into surgery within the next few hours. The appendix is inflamed but hasn't ruptured yet, so this should be straightforward. Straightforward. The word would haunt me for months afterward. A reminder that even the most routine medical procedures can take unexpected and terrifying turns. Thompson scheduled my surgery for that evening, assuring me that I would be back to work within a week and that the laparoscopic procedure would leave only minimal scarring. As the hours passed and my surgery time approached, the pain intensified beyond anything I had experienced in my medical career. The morphine that the nurses administered provided only temporary relief, and I found myself checking my watch constantly, counting the minutes until I could be wheeled into the operating room and freed from the mounting agony. Dr. James Rodriguez, the anesthesiologist who would be managing my case, visited me in the preoperative holding area to discuss the anesthesia plan. I had worked with Dr. Rodriguez numerous times, observing his calm professionalism during countless emergency surgeries. His presence was reassuring as he explained the standard general anesthesia protocol that would keep me unconscious and pain-free during the procedure. "You'll be completely under," he assured me, as he reviewed my medical history for any potential complications. "The propofol will put you out quickly, and the sevoflurane will keep you under for the duration of the surgery." Most patients don't remember anything from the time they count backward until they wake up in recovery. Most patients, the qualification would prove to be more significant than either of us realized at the time. As I was wheeled into operating room 3, the familiar sights and sounds of the surgical environment surrounded me. The bright overhead lights, the rhythmic beeping of monitoring equipment, the controlled movements of the surgical team preparing their instruments and reviewing their procedures. Dr. Thompson smiled at me from behind her surgical mask as the anesthesia team prepared to begin the induction process. "See you on the other side, Sarah," she said with the casual confidence that comes from performing thousands of successful surgeries. "This will be over before you know it." The anesthesia mask was placed over my face, and Dr. Rodriguez instructed me to begin counting backward from 10. The familiar ritual of pre-surgical anesthesia, something I had witnessed from the other side countless times during my career. 10, 9, 8, 7, and then darkness claimed me as the propofol took effect and consciousness faded away. What happened next defied every principle of anesthesiology and consciousness that I had learned during my medical training. Instead of the peaceful oblivion that general anesthesia is supposed to provide, I found myself in a state of heightened awareness, fully conscious and able to perceive everything happening around me while being completely unable to move or communicate my awareness to the surgical team. The medical term for this nightmare scenario is anesthesia awareness, a rare but documented phenomenon that occurs in approximately 1 to 2 cases per 1,000 surgeries. Patients experiencing anesthesia awareness remain conscious during surgery while being unable to move or indicate their awareness due to the neuromuscular blocking agents used in modern anesthesia protocols. But what I experienced went far beyond the documented cases of anesthesia awareness that I had studied during my medical training. As the surgery began, I could feel every incision, every manipulation of tissue, every movement of surgical instruments with a clarity and intensity that seemed impossible under general anesthesia. The pain was indescribable, but even more disturbing was my complete inability to communicate my awareness to the surgical team working on my exposed abdomen. Dr. Thompson's voice was calm and professional as she began the laparoscopic procedure, making the small incisions that would allow her to visualize and remove my inflamed appendix. Two pneuma peritoneum established. She announced as carbon dioxide was insufflated into my abdominal cavity to create working space for the surgical instruments. I could feel the gas expanding my abdomen, creating pressure and discomfort that added to the already overwhelming sensations of the surgery. But worse than the physical discomfort was the growing realization that something was seriously wrong with my anesthesia. I should have been completely unconscious, experiencing nothing until I awoke in the recovery room. Dr. Rodriguez's voice carried the first note of concern as he monitored my vital signs during the early stages of the procedure. Blood pressure is climbing, he announced to the surgical team. Side rate increasing to 120 beats per minute. These are unusual responses for someone under adequate general anesthesia. Unusual responses. My body was trying to communicate what my voice could not, that I was fully aware and experiencing every moment of the surgery with crystal clarity. But the paralytic agents in my system prevented any voluntary movement that might alert the team to my conscious state. As the surgery progressed, Dr. Thompson encountered complications that transformed what should have been a routine appendectomy into an increasingly complex and lengthy procedure. The appendix is more inflamed than the imaging suggested, she reported to the team. There's significant adhesion to surrounding tissue, and I'm seeing signs of early perforation. Early perforation. The word sent a chill through my conscious mind as I realized that my condition was more serious than anyone had initially recognized. A perforated appendix could lead to peritonitis, sepsis, and life-threatening complications that would require extensive surgical intervention. Dr. Thompson's voice became more tense as she worked to address the complications she was discovering. Solid better visualization. The inflammation is extensive, and I'm having difficulty identifying normal anatomical landmarks. We may need to convert to an open procedure. Converting to an open procedure meant making a much larger incision, extending the surgery time, and increasing the risks associated with the operation. But from my helpless position on the operating table, I could only listen as the team made decisions about my body and my life, while remaining completely unaware of my conscious observation of their every word and action. The surgery continued for what felt like hours, during which I experienced every moment of the procedure with an awareness that seemed impossibly acute. I could hear conversations between team members, feel the manipulation of my internal organs, and sense the growing tension in the operating room as the complications mounted. Dr. Rodriguez provided regular updates on my vital signs, noting increasing instability that should have been impossible under proper general anesthesia. Blood pressure is becoming erratic, he reported with growing concern. I'm seeing cardiac arrhythmias that don't correspond with the anesthesia depth indicators. Cardiac arrhythmias. My heart was responding to the stress and pain of surgery, despite the anesthetic agents that should have blocked all awareness and physiological responses. My body was betraying the inadequacy of my anesthesia through vital sign changes that the team was struggling to understand. As Dr. Thompson worked to address the complications in my abdominal cavity, she encountered bleeding that required immediate attention. I've got arterial bleeding from the appendiceal artery, she announced urgently. Suction and cautery, please. Blood pressure is dropping rapidly. I could feel my life force ebbing away as blood loss mounted, and my cardiovascular system began to fail. The sensation was unlike anything I could have imagined. A gradual dimming of consciousness combined with an increasingly profound sense of disconnection from my physical body. Dr. Rodriguez's voice carried increasing alarm as my vital signs deteriorated. Blood pressure is 60/30 and falling, heart rate dropping to 40 beats per minute. We're losing her. The clinical terminology for my approaching death, spoken with the professional detachment that medical training requires even in the most dire circumstances. But from my perspective, as the patient, the words carried a weight and immediacy that no amount of medical training could have prepared me for. The operating room erupted into controlled chaos as the surgical team worked frantically to address the life-threatening complications that had developed during what should have been a routine procedure. I could hear orders being shouted, equipment being moved, and the urgent footsteps of additional medical personnel being called into the room. "Start massive transfusion protocol," Dr. Thompson ordered. As she worked to control the bleeding in my abdomen, type and cross-match for 6 units of packed red blood cells, fresh frozen plasma, and platelets. "We need to get her pressure up now." Massive transfusion protocol, the emergency response reserved for patients who are bleeding to death, requiring immediate replacement of blood volume to prevent cardiovascular collapse and death. I was dying on the operating table, and despite my continued consciousness, I was powerless to communicate or participate in the desperate efforts to save my life. Dr. Rodriguez was working frantically to maintain my cardiovascular stability as the anesthesia became secondary to the immediate threat of exsanguination. Epinephrine, atropine, and dopamine infusions started, he reported, but we're not getting adequate response. Cardiac output is critically low. The medications coursed through my system, creating sensations of artificial stimulation and cardiovascular support that felt foreign and disturbing. But even with pharmaceutical intervention, my vital signs continued to deteriorate as the surgical complications overwhelmed the team's efforts to maintain my stability. As minutes passed that felt like hours, I became aware of a strange duality in my experience. While my body was failing and my vital signs were indicating impending death, my consciousness seemed to be becoming more acute and aware rather than less. I could perceive conversations and activities throughout the operating room with a clarity that seemed impossible under any medical circumstances. Dr. Thompson's voice carried desperation as she struggled to control the bleeding that was threatening my life. "I can't get adequate visualization. There's too much blood, and the tissues are too friable from the inflammation. We're fighting a losing battle here." A losing battle. The surgical team was acknowledging that their efforts to save my life were failing, that the complications had progressed beyond their ability to manage effectively. I was dying, and everyone in the operating room knew it. The cardiac monitor's alarms were now sounding continuously as my heart rhythm became increasingly unstable. The steady beeping that had provided a reassuring background soundtrack to the surgery was replaced by the urgent, piercing tones that indicate life-threatening cardiac arrhythmias. "VFib," Dr. Rodriguez announced tersely. "Starting chest compressions and charging the defibrillator. Everyone clear." Ventricular fibrillation. My heart had stopped beating effectively, instead quivering uselessly in my chest as electrical chaos overwhelmed the normal cardiac conduction system. I was experiencing cardiac arrest on the operating table, the ultimate medical emergency that frequently marks the transition from life to death. The defibrillation shock coursed through my body with an intensity that no amount of medical training could have prepared me for. The electrical current caused every muscle in my body to contract simultaneously, creating a sensation of violent, overwhelming force that seemed to tear through every cell. "No response," Dr. Rodriguez reported after checking the cardiac monitor following the first shock. "Continue chest compressions and prepare for another shock at 200 joules. No response." My heart had not resumed normal rhythm, despite the defibrillation attempt. The chest compressions being performed on my exposed chest created pressure and discomfort that added to the already overwhelming sensory experience of cardiac arrest. Though second shock, more powerful than the first, coursed through my body without restoring normal cardiac function. Rodriguez continued the resuscitation efforts with professional determination, but I could hear the growing desperation in his voice as my body failed to respond to the emergency interventions. "Still no organized rhythm," he announced after the second defibrillation attempt. "Continue CPR and push another round of epinephrine." "How long have we been down?" "8 minutes of cardiac arrest," someone replied, though I couldn't identify the voice through the chaos of the resuscitation efforts. 8 minutes without effective cardiac function, well beyond the time frame when most patients can be successfully resuscitated without significant neurological damage. Dr. Thompson had stopped the surgical procedure entirely, focusing all attention on the cardiac emergency that was threatening to end my life. "Sarah, stay with us," she said, speaking directly to my unconscious form for the first time during the procedure. "We're not giving up on you." But I was still there, still conscious, still aware of every word and every action, despite the fact that my heart had stopped beating and my blood pressure was undetectable. The consciousness that should have been extinguished by cardiac arrest remained strangely intact, observing the desperate efforts to restore life to my failing body. Additional medical personnel had been called into the operating room, expanding the resuscitation team and bringing additional expertise to bear on my cardiac emergency. I could hear multiple voices coordinating the emergency response, adjusting medications, and discussing the rapidly diminishing chances of successful resuscitation. 15 minutes of downtime, Dr. Rodriguez reported with growing resignation in his voice. "We've tried everything, multiple defibrillations, maximum dose epinephrine, atropine, bicarbonate, calcium, nothing is working." 15 minutes. The duration of my cardiac arrest had extended well beyond the time frame when successful resuscitation is possible without devastating neurological consequences. Even if they managed to restore my heart rhythm, the prolonged period without circulation would likely result in severe brain damage or vegetative state. Dr. Thompson's voice carried the weight of defeat as she surveyed the unsuccessful resuscitation efforts. "How much longer do we continue? At this point, even if we get her back, the neurological prognosis is going to be devastating." The question that every medical team faces during prolonged resuscitation efforts: when to continue fighting for life and when to accept that death is inevitable. The decision involves not just medical considerations, but ethical ones about the quality of life that might remain even after successful resuscitation. But from my unique perspective, as a conscious observer of my own resuscitation, I wanted to scream that I was still aware, still present, still hoping that they would continue their efforts to save my life. The consciousness that medical science predicted should have been extinguished by prolonged cardiac arrest remained vibrantly alive and aware. Dr. Rodriguez checked the cardiac monitor once more, looking for any sign of electrical activity that might indicate a chance of successful resuscitation. I'm seeing some agonal rhythms, but nothing organized. No pulse, no blood pressure, no response to maximum interventions. Agonal rhythms, the final ineffective electrical activity that often precedes complete cardiac death. The monitor was showing the electrical evidence of my approaching death, yet my consciousness remained mysteriously intact and aware of the grim pronouncement. "Time of death," Dr. Thompson said quietly, her voice heavy with professional sadness and personal grief. Time of death. The official declaration that my life had ended, that the resuscitation efforts had failed, and that I was now legally and medically deceased. Yet I remained conscious and aware, listening to the pronouncement of my own death with a clarity that seemed impossible under any medical circumstance. The operating room fell silent, except for the mechanical hum of equipment and the quiet movements of the team as they began the somber process of discontinuing life support measures and preparing my body for post-mortem procedures. The frantic energy of resuscitation was replaced by the subdued atmosphere of death and loss. Dr. Rodriguez began the process of disconnecting the monitors and ventilator equipment that had been sustaining my body during the failed resuscitation attempts. "I'll contact the family and Dr. Miller from pathology for post-mortem examination," he said to Dr. Thompson. Post-mortem examination, an autopsy to determine the cause of death and investigate the surgical complications that had led to my demise. The clinical procedures that followed death, conducted on what everyone believed was my lifeless body. But I was still there, still conscious, still aware of every word and action as the team began treating me as a deceased patient rather than a living human being. The consciousness that should have ended with my cardiac death remained mysteriously present, observing the aftermath of my own mortality. The surgical instruments were cleaned and removed from my body, and the surgical incisions were temporarily closed to prepare my body for transfer to the morgue. I could feel every manipulation of my supposedly lifeless form, a sensation that was both surreal and deeply disturbing. Dr. Thompson removed her surgical gloves and mask, her movements slow and heavy with the weight of losing a patient and colleague. "Sarah was a good doctor and a good person," she said to the assembled team. "This shouldn't have happened. This shouldn't have happened." The acknowledgement that my death was unexpected and potentially preventable, that the routine appendectomy had taken a tragic turn that no one had anticipated. But despite her words and the finality of the death declaration, my consciousness persisted in observing the scene of my own demise. The operating room was being prepared for cleanup and sterilization when Nurse Patricia Williams entered to begin the process of preparing my body for transport to the morgue. Nurse Williams had worked with me countless times during my years at the hospital, and I could see the sadness in her movements as she approached what everyone believed was my corpse. She began the routine post-mortem care, checking identification bands and beginning the documentation that accompanies death in a hospital setting. But as she placed her hand on my wrist to check for the absence of pulse that would confirm my death, something extraordinary happened. "Wait," she said suddenly, her voice sharp with surprise and confusion. The room fell silent as Nurse Williams pressed her fingers more firmly against my wrist, checking for signs of life that everyone knew should be impossible after 23 minutes of failed resuscitation efforts. "There's definitely something here," she announced, with growing excitement and disbelief. "It's weak, but I'm getting a pulse. Dr. Rodriguez, you need to check this immediately." Dr. Rodriguez rushed back to my bedside, his face showing the skepticism that medical training instills when confronted with claims that seem impossible. But as he placed his stethoscope on my chest and palpated my wrist and neck for signs of circulation, his expression changed from skepticism to amazement. "Jesus Christ," he whispered, his professional composure cracking under the weight of what he was discovering. "She's got a pulse. Weak and irregular, but definitely present. How is this possible? How is this possible?" The question that would haunt my medical team for months afterward, challenging their understanding of death, resuscitation, and the boundaries of human survival. I had returned from clinical death after a period that should have made recovery impossible. The operating room exploded back into controlled chaos as the team rushed to reconnect monitoring equipment and assess my returning vital signs. The machines that had been disconnected just minutes earlier were hastily reattached as everyone struggled to understand what they were witnessing. "Blood pressure is 60/40, Dr. Rodriguez announced as he inflated the cuff around my arm. "Heart rate is 55 and irregular, but she's definitely got spontaneous circulation. This is medically impossible." Medically impossible, the phrase that would define my case for the medical professionals trying to understand how I had returned to life after being declared dead. But from my perspective as the conscious observer of my own resurrection, the impossible was becoming my reality. Dr. Thompson had returned to my bedside, her face showing a mixture of hope, confusion, and professional bewilderment as she assessed my returning signs of life. "Neurological status?" she asked Dr. Rodriguez while checking my pupillary responses. "Pupils are equal and reactive," he reported after shining a light in my eyes. "But she's still completely unresponsive to verbal or physical stimuli. It's like she's in a deep coma despite having adequate vital signs." A deep coma. The medical explanation for my unresponsiveness, not knowing that I was fully conscious and aware, but unable to communicate due to the residual effects of the anesthetic and paralytic agents still circulating in my system. The team worked frantically to stabilize my mysteriously returning vital signs while struggling to understand the medical phenomenon they were witnessing. Blood pressure medications, cardiac monitoring, and neurological assessments filled the next hour as they tried to make sense of my resurrection. "We need to get her to the ICU immediately," Dr. Thompson decided. "Whatever's happening here, she needs intensive monitoring and supportive care, and we need to contact every specialist in the hospital. This is beyond anything I've ever seen." The transfer to the intensive care unit was a blur of activity and medical interventions as the team worked to support my returning physiological functions while grappling with the impossibility of what had occurred. I remained conscious throughout the transfer, aware of every conversation and every medical decision being made on my behalf. The ICU was a familiar environment from my years as an emergency physician, but experiencing it as a patient was entirely different. The constant monitoring, the frequent assessments, the controlled environment designed to support critically ill patients, all of it took on new meaning when viewed from the perspective of the patient rather than the physician. The Dr. Elizabeth Chen, the chief of critical care medicine, took over my case with the systematic approach that intensive care requires. "Let me understand this correctly," she said to Dr. Thompson during the handoff report. "She was declared dead after 23 minutes of failed resuscitation and then spontaneously regained vital signs." "That's exactly right," Dr. Thompson confirmed. "We had discontinued all life support measures and were preparing the body for post-mortem care when the nurse detected a pulse. It's completely unprecedented in my surgical experience. Completely unprecedented. My case was already being recognized as something beyond normal medical experience, a phenomenon that would require investigation and documentation that extended far beyond routine patient care. As the hours passed in the ICU, I remained conscious, but unable to communicate my awareness to the medical team caring for me. The anesthetic agents that had failed to provide unconsciousness during surgery were now preventing me from indicating that I was awake and aware despite appearing to be in a deep coma. Dr. Chen ordered comprehensive neurological testing to assess the extent of any brain damage that might have resulted from the prolonged period of cardiac arrest. CT scans, MRI imaging, and electroencephalography were scheduled to evaluate my neurological status and prognosis. "The EEG results are fascinating," Dr. Sarah Patterson, the consulting neurologist, reported to Dr. Chen after reviewing my brainwave patterns. "She's showing electrical activity consistent with full consciousness despite appearing completely unresponsive. I've never seen patterns like this." Full consciousness. The EEG was detecting what I knew to be true, that despite my apparent coma state, my brain was functioning at full capacity and maintaining complete awareness of my surroundings and circumstances. The medical consultations continued throughout my first day in the ICU as specialists from various departments tried to understand what had happened during my surgery and subsequent resurrection. Cardiologists, neurologists, anesthesiologists, and even psychiatrists were called in to evaluate my case. Dr. Michael Torres, the consulting cardiologist, reviewed my cardiac enzymes and ECG patterns with particular interest. The cardiac markers indicate that she definitely sustained a significant heart attack during the surgery, he explained to the assembled team. But the patterns don't correlate with what we would expect from someone who experienced 23 minutes of cardiac arrest. The cardiac evidence supported what I had experienced. My heart had indeed stopped beating for an extended period, yet somehow I had survived with what appeared to be minimal damage to my cardiac muscle. As the medical evaluations continued, I became aware that my case was attracting attention beyond the immediate medical team. Researchers, medical students, and even physicians from other hospitals were requesting permission to review my records and examine the patient who had returned from clinical death. Dr. Chen was fielding calls from medical journals, research institutions, and even media outlets that had learned about the unusual circumstances of my case. We need to be very careful about patient privacy and family consent before we allow any research participation or media coverage, she warned the team. But from my conscious but uncommunicative position in the ICU bed, I was fascinated by the scientific interest that my experience was generating. As a physician myself, I understood the significance of my case for advancing medical knowledge about consciousness, death, and resuscitation. My family had been notified of both my death and subsequent resurrection, creating emotional trauma that would affect them for years afterward. My husband David and my 2 teenage children had experienced the devastating news of my death, followed hours later by the miraculous news of my return to life. David spent hours at my bedside talking to me despite my apparent unconsciousness, hoping that some part of me could hear and understand his words. If only he knew that I was fully aware and desperately wishing I could respond to his loving presence and worried voice. "The kids are scared," he told my motionless form during one of his visits. "They don't understand how you can be alive, but not wake up. Hell, I don't understand it either. The doctors keep saying it's impossible, but here you are." But it was during one of his late-night vigils that David broke down completely. I heard him crying, something I had witnessed only twice in our 15-year marriage. "Sarah, I need you to wake up," he whispered through his tears. "I can't do this alone. The kids need their mother, and I need my wife. Whatever happened in that operating room, whatever you experienced, we'll figure it out together. Just please come back to us." The desperation in his voice was heartbreaking. David had always been the strong one in our relationship, the steady presence who could handle any crisis, but my prolonged unconsciousness was breaking him down, and I was powerless to comfort him or let him know that I was still there, still fighting to return to our family. When I finally began showing signs of consciousness, David's relief was overwhelming. But as the days passed and I gradually revealed some of my memories from the surgery, his relief transformed into something more complex and troubling. "You remember what, Sarah?" he asked, when I first mentioned hearing conversations during the surgery. "You were unconscious. You were dead for over 20 minutes. People don't remember things when they're dead." The tension in our marriage escalated when I began sharing more detailed memories with David. I told him about hearing Dr. Thompson discuss the complications, about the conversations during my cardiac arrest, about the moment they declared my time of death. With each revelation, David's expression grew more concerned and distant. "Sarah, honey, I think you need to talk to someone," he said gently, but firmly after I described hearing the post-mortem preparations. "A psychiatrist? I mean, this level of detailed memory from when you were clinically dead, it's not possible. Maybe the trauma of the surgery created false memories, or maybe the medications affected your perception of events." False memories. The suggestion that my most profound and terrifying experience might be a psychological fabrication was devastating. David's doubt, combined with my own medical knowledge about the impossibility of consciousness during clinical death, created a crisis of self-doubt that was almost as traumatic as the original experience. Our children, Emma and Jake, both teenagers, were struggling with their own trauma from the experience. They had been told their mother was dead, then hours later informed that I was alive but might have brain damage, then eventually that I was recovering, but different in ways no one could explain. "Mom, you're scaring me," Emma said during one of my first days home from the hospital. "You keep talking about things that happened when you were gone. It's like you're a different person." But the most significant drama was yet to come. 3 weeks after my discharge from the hospital, Dr. Thompson requested a private meeting with me in her office. Her demeanor was professional but tense, and I could see the conflict in her expression as she struggled with what she needed to say. "Sarah, I need to discuss something sensitive with you," she began, closing the office door and ensuring we had complete privacy. "Your case has attracted attention from the hospital administration, the medical board, and even some external organizations that I can't discuss in detail." External organizations. The phrase sent a chill through me as I realized that my experience was being viewed as more than just a medical anomaly. There were implications and interests involved that extended beyond patient care and medical research. Dr. Thompson continued, her voice carrying a weight of professional concern mixed with personal worry. "There are people who believe that your detailed memories of the surgical procedure and the resuscitation attempts represent a serious breach of patient confidentiality and medical privacy, even though you were the patient involved." The accusation was stunning. They were suggesting that my memory of my own medical care somehow violated confidentiality protocols, that my consciousness during the surgery had made me an unauthorized observer of medical procedures. "More concerning," Dr. Thompson continued, "there are questions about whether your claims of consciousness during clinical death might be fabricated or exaggerated for attention or potential legal action against the hospital." Legal action. The implication that I might be creating false memories or exaggerating my experience for financial gain was both insulting and terrifying. My medical career, my reputation, and my integrity were all being questioned because I had survived something that medical science couldn't explain. "Sarah, I need you to understand that there are powerful people who want this case to disappear quietly. Your survival challenges too many assumptions, and your memories raise too many uncomfortable questions about what really happens during medical procedures." The conversation revealed a level of institutional pressure and potential cover-up that I had never imagined could exist in the medical community. The hospital administration was more concerned about protecting institutional reputation than understanding or acknowledging the medical phenomenon I had experienced. Dr. Thompson handed me a document that made my blood run cold. "They want you to sign this statement, indicating that your memories of the surgical procedure were the result of anesthesia-induced hallucinations, and that you have no intention of pursuing any legal action or public disclosure of the events." Here you are, the simple acknowledgement of my continued existence despite the medical impossibility of my survival. David's faith in my presence was more accurate than any of the medical assessments being conducted by the specialists evaluating my case. As days passed, my consciousness remained trapped in my unresponsive body, while my vital signs gradually stabilized and strengthened. The medical team was cautiously optimistic about my physical recovery, but remained baffled by my persistent unconsciousness and the circumstances of my resurrection. Dr. Patterson conducted daily neurological assessments, looking for any sign of awakening or response that might indicate emerging consciousness. She had no way of knowing that I was fully aware during every examination, desperately trying to communicate through small movements or responses that the residual anesthetic effects prevented. Her reflexes are normal, and the EEG continues to show patterns consistent with consciousness, Dr. Patterson reported to the team during daily rounds. But there's still no evidence of purposeful response or awareness. It's like her consciousness is there but locked inside. Locked inside. The perfect description of my predicament. Fully conscious and aware, but unable to communicate my presence to the people working so hard to help me recover from my impossible survival. The breakthrough came on my 5th day in the ICU, when the last of the anesthetic agents finally cleared from my system, enough to allow voluntary muscle control. I managed to squeeze David's hand during one of his visits, a small movement that sent shockwaves through the medical team and brought tears of joy to my family. "She squeezed my hand," David announced excitedly to Nurse Johnson, who immediately called Dr. Chen and Dr. Patterson to evaluate my first sign of voluntary movement since the surgery. The neurological examination that followed was the most thorough assessment I had ever experienced. Even from my perspective as a physician, every reflex, every response, every sign of consciousness was carefully evaluated and documented as evidence of my emerging recovery. "Sarah, can you hear me?" Dr. Patterson asked, while shining a light in my eyes and checking my pupillary responses. "If you can understand what I'm saying, try to blink twice." 2 deliberate blinks, the simple response that confirmed what I had known all along, that I had been conscious and aware throughout my entire ordeal, from the surgery through the death declaration and subsequent resurrection. The medical team's excitement was palpable as they confirmed my consciousness and began the process of evaluating my cognitive function and memory retention. They had no idea that I remembered everything, every word of conversation during my surgery, every moment of the failed resuscitation, every discussion about my case during my days in the ICU. As my ability to communicate gradually returned, I faced the decision of how much to reveal about my extraordinary experience. The medical implications of conscious awareness during clinical death challenged fundamental assumptions about consciousness, memory, and the nature of human survival. So Dr. Chen and Dr. Patterson conducted extensive interviews about my memories and experiences during the surgery and subsequent period of unconsciousness. They were particularly interested in whether I retained any awareness during what should have been complete anesthesia and clinical death. I chose to reveal some of my memories gradually, testing the medical team's reaction to my claims of consciousness during supposedly unconscious states. Their responses ranged from fascination to skepticism, with most physicians struggling to reconcile my detailed memories with their understanding of anesthesia and consciousness. "You remember conversations that took place during your surgery?" Dr. Patterson asked, with a mixture of professional interest and personal amazement. "That should be impossible under general anesthesia, especially given the depth of anesthesia required for abdominal surgery." Impossible, the word that defined my entire experience, yet the medical evidence supported my claims. The EEG recordings from my surgery show brain activity patterns consistent with consciousness throughout the procedure, even during the period of cardiac arrest. As my recovery progressed and I regained full neurological function, my case became the subject of intense medical investigation and research. The combination of anesthesia awareness, conscious experience during clinical death, and successful resuscitation after prolonged cardiac arrest created a unique case study that challenged multiple areas of medical knowledge. Medical journals competed to publish the first comprehensive report of my case, while researchers from neuroscience, anesthesiology, and consciousness studies requested permission to conduct additional testing and investigation. But beyond the medical fascination with my experience, the personal impact of conscious awareness during clinical death had profound effects on my understanding of life, consciousness, and mortality. The experience changed my perspective on what it means to be alive and conscious in ways that would influence every aspect of my future medical practice and personal life. The memory of hearing my own death declared while remaining conscious and aware created psychological challenges that required professional counseling and support. The trauma of experiencing surgery without adequate anesthesia, combined with the existential impact of conscious death experience, affected my emotional and psychological well-being for months afterward. My return to medical practice was complicated by the knowledge that I had gained through my impossible experience. The insights into consciousness, death, and survival that I had acquired through personal trauma gave me perspectives on patient care that were both valuable and emotionally challenging. Colleagues treated me with a mixture of fascination and unease, unsure how to relate to someone who had experienced and survived circumstances that challenged their understanding of medical reality. Some viewed me as a medical curiosity, while others sought my insights into consciousness and near-death experiences. The research that emerged from my case contributed to advances in anesthesia monitoring, consciousness assessment, and resuscitation protocols that improve patient care and safety. The EEG patterns recorded during my surgery provided new insights into consciousness during anesthesia that led to better monitoring techniques and reduced incidents of anesthesia awareness. My experience also contributed to research into consciousness persistence during clinical death, a phenomenon that had been reported anecdotally but never documented with the comprehensive medical monitoring that my case provided. The implications for understanding consciousness, memory, and survival extended far beyond individual medical cases to fundamental questions about the nature of human awareness. The psychological impact of conscious death experience became a new area of research interest, with mental health professionals studying the unique trauma and insights that result from awareness during clinical death. My experience provided a case study for understanding and treating the psychological consequences of impossible survival. Today, as I continue my medical practice with the knowledge and perspective gained through my extraordinary experience, I serve as both a physician and a living example of the mysteries that remain in medical science. The consciousness that persisted through clinical death continues to influence my understanding of patient care, medical ethics, and the fundamental questions about life and death that every physician encounters. The experience taught me that the boundaries between life and death are far more complex and mysterious than medical training suggests. The consciousness that I retained during clinical death provided insights into the nature of human awareness that continue to influence my approach to patient care and my understanding of what it means to be truly alive. My case has become part of medical literature and consciousness research, contributing to ongoing investigations into anesthesia awareness, clinical death experiences, and the persistence of consciousness under extreme medical circumstances. The implications of my experience continue to influence research and understanding in multiple areas of medical science. But perhaps most importantly, my impossible survival and conscious death experience serve as a reminder that human consciousness and the will to live are more resilient and mysterious than any medical textbook can fully explain. The awareness that persisted through my clinical death demonstrates that our understanding of consciousness, life, and death remains incomplete and full of possibilities that challenge our most fundamental assumptions about human existence. The medical impossibility of my experience became a medical reality that expanded our understanding of what is possible in human survival and consciousness. The consciousness that observed its own death and resurrection provided insights that continue to influence medical practice, research, and our fundamental understanding of what it means to be human and alive. My story serves as testimony to the mystery and resilience of human consciousness, the importance of continued medical research into consciousness and survival, and the recognition that even in our advanced medical age, there remain phenomena that challenge our understanding and expand our knowledge of the incredible potential of human awareness and survival. The months that followed my return to consciousness brought revelations that extended far beyond my individual case. As I worked with researchers to document and understand my experience, we discovered that I wasn't entirely alone in having conscious awareness during clinical death. Medical literature, when carefully examined, contains scattered reports of similar cases dating back decades, though most had been dismissed as hallucinations or false memories. Dr. Patterson connected me with Dr. Michael Harrison, a consciousness researcher at Johns Hopkins who had been studying unusual anesthesia responses and awareness cases for over 10 years. His research had documented 18 similar cases of patients who reported detailed memories of medical procedures that occurred during periods when they should have been unconscious or unresponsive. Your case is unique because of the comprehensive medical monitoring we have, Dr. Harrison explained during our first meeting. Most patients who report conscious death experiences are dismissed because there's no objective evidence to support their claims. But your EEG recordings during cardiac arrest show clear patterns of consciousness that should be impossible. The EEG evidence from my surgery had indeed captured something unprecedented, The brainwave patterns recorded during my 23 minutes of cardiac arrest showed not the flat line that medical science predicted, but complex electrical activity that resembled heightened states of consciousness rather than the absence of brain function. Dr. Harrison's research had identified some patterns among patients who experienced anesthesia awareness during cardiac emergencies. Most were healthcare professionals or individuals who had previously undergone multiple surgical procedures. Many had histories of unusual responses to anesthesia or required higher than normal doses for adequate sedation. Some patients report heightened sensitivity to subtle medical changes after experiencing anesthesia awareness during cardiac events. Dr. Harrison explained as he reviewed psychological profiles from his case studies. They become more attuned to physiological cues that most people wouldn't notice, changes in skin color, breathing patterns, or other indicators of medical distress. Heightened sensitivity to medical indicators. As Dr. Harrison described these changes, I realized that I had been experiencing something similar. Since my recovery, I had noticed myself picking up on subtle signs in patients that I might have missed before: slight changes in respiratory rate, barely perceptible color changes in skin tone, or minor alterations in posture that could indicate developing medical problems. This increased observational ability had proven clinically useful on several occasions. The patient who came to the emergency room with vague complaints triggered my attention due to subtle signs that led me to order more extensive testing than his symptoms would normally warrant. The tests revealed early stages of a serious condition that required immediate treatment, but I remained uncertain whether these observations represented genuine enhancement of my medical skills or simply increased anxiety and hypervigilance resulting from my traumatic surgical experience. The psychological impact of conscious awareness during life-threatening medical procedures could easily explain heightened attention to medical details and patient symptoms. Dr. Harrison had developed specialized EEG protocols that could identify subtle patterns in patients who had experienced anesthesia awareness during cardiac emergencies. These patterns, while not dramatically different from normal brain activity, showed consistent variations that appeared in his case studies. The EEG changes are subtle but measurable, Dr. Harrison explained while reviewing my test results. They suggest that the experience of maintaining consciousness during extreme medical situations may create lasting alterations in how the brain processes awareness and attention. The research implications were significant, but remained preliminary. Dr. Harrison was collaborating with anesthesiologists to better understand why certain patients maintained awareness during procedures that should render them completely unconscious. The goal was to improve anesthesia protocols and reduce the incidence of awareness during surgery. My participation in this research involved periodic EEG monitoring, psychological assessments, and detailed interviews about my ongoing recovery and any changes in my cognitive function or medical practice. The research was conducted carefully, with full informed consent and institutional review board approval. The psychological impact of my experience extended beyond any potential changes in medical intuition. The memory of hearing my own death declared while remaining conscious created ongoing anxiety about medical procedures and mortality that required professional counseling to address effectively. Working with Dr. Lisa Martinez, a psychologist who specialized in medical trauma, I gradually learned to process the psychological impact of my extraordinary experience. The combination of surgical trauma, anesthesia awareness, and the existential impact of conscious death experience created complex emotional challenges that affected both my personal life and professional practice. Patients who experience consciousness during life-threatening medical events often develop what we call medical hypervigilance, Dr. Martinez explained during our sessions. They become extremely attuned to physical symptoms and medical details, sometimes to a degree that interferes with normal daily functioning. The hypervigilance was indeed something I experienced. Every minor physical symptom triggered anxiety about potential medical emergencies. My knowledge of medicine, combined with the trauma of my surgical experience, created a cycle of worry and excessive attention to bodily sensations that was exhausting to maintain. But the counseling also helped me recognize the positive aspects of my experience. The heightened attention to patient care and medical details, while sometimes overwhelming, had genuinely improved my effectiveness as an emergency physician. I was more thorough in my assessments, more careful in my differential diagnoses, and more empathetic toward patients experiencing medical crises. The research into consciousness during cardiac emergencies remained limited due to the rarity of the phenomenon and the ethical constraints of studying it. Harrison could only work with cases that occurred naturally during medical emergencies, making it difficult to gather comprehensive data or develop controlled studies. But the research had already contributed to improvements in anesthesia monitoring. The EEG patterns identified in awareness cases had led to better protocols for detecting consciousness during surgery and adjusting anesthesia accordingly. These improvements potentially prevented other patients from experiencing the trauma of surgical awareness. My case became part of a small but growing body of literature on anesthesia awareness and consciousness during cardiac events. The comprehensive medical monitoring that had documented my experience provided valuable data for understanding these rare but significant medical phenomena. The ongoing research also contributed to better support protocols for patients who experience anesthesia awareness. Recognition that the psychological trauma could be as significant as any physical complications led to improved counseling services and follow-up care for affected patients. We're essentially dealing with a new category of neurological condition, Dr. Harrison explained during one of our research meetings. Consciousness survival during clinical death appears to create permanent alterations in neural function that we don't yet understand and can't currently treat effectively. The treatment challenges were significant because the consciousness changes couldn't be detected through conventional neurological testing. CT scans, MRI imaging, and standard EEG recordings showed normal brain function despite the profound alterations in consciousness and perception that survivors experienced. Dr. Harrison had developed specialized testing protocols using advanced EEG technology that could detect subtle but consistent patterns in the brain activity of consciousness survivors. These patterns, which he termed post-mortem consciousness signatures, were present in all documented cases of clinical death survival with retained awareness. The signature patterns suggest that the neural pathways responsible for consciousness become fundamentally rewired during the clinical death experience. Dr. Harrison explained, while reviewing my latest EEG results, it's as if the brain develops new methods for processing awareness that bypass normal neurological function. The implications for neuroscience and consciousness research were revolutionary. If clinical death could create new neural pathways for consciousness, it suggested that human awareness was far more adaptable and resilient than previously understood. The research could potentially lead to new treatments for coma, brain injury, and neurodegenerative diseases. But the practical challenges of conducting research on consciousness survival were enormous. Ethical considerations prevented deliberately inducing clinical death in research subjects. The phenomenon occurred unpredictably during medical emergencies, making it impossible to study under controlled conditions, and the subjective nature of consciousness made it difficult to develop objective measurement criteria. Despite these challenges, Dr. Harrison had begun collaborating with researchers at major medical institutions to develop protocols for identifying and studying consciousness survivors. The goal was to create a comprehensive database of cases that could support more extensive research into the mechanisms and implications of consciousness persistence during clinical death. My participation in this research became a significant part of my post-recovery life. The medical knowledge gained through my impossible experience created both opportunities and responsibilities that extended far beyond my individual case. I found myself serving as a bridge between the scientific medical community and the hidden population of consciousness survivors who had experienced similar phenomena. The psychological support network that developed among consciousness survivors became essential for managing the ongoing challenges of altered awareness. We shared coping strategies, supported each other through difficult periods of consciousness instability, and worked together to document our experiences for research purposes. But perhaps most importantly, we served as living proof that human consciousness was more mysterious and resilient than medical science currently acknowledged. Our experiences suggested that the boundary between life and death was far more complex than previously understood, and that consciousness itself might be capable of survival under circumstances that challenged every assumption about the nature of human awareness. The ongoing research into consciousness survival during clinical death continues to reveal new insights into the fundamental nature of human awareness and its relationship to physical brain function. Each new case study adds to our understanding of consciousness as a phenomenon that may extend beyond the traditional boundaries of neurological function and biological survival. For me, the experience of conscious clinical death and subsequent consciousness alteration has become both a personal journey of adaptation and a professional opportunity to contribute to expanding medical knowledge. The awareness that survived my clinical death continues to influence every aspect of my medical practice and my understanding of what it means to be truly alive and conscious. The mystery of consciousness persistence during clinical death remains unsolved, but the growing body of research and the expanding community of survivors continues to challenge medical science to expand its understanding of human awareness and the fundamental nature of consciousness itself. We are living proof that the boundaries between life and death, consciousness and unconsciousness, are far more fluid and mysterious than medical textbooks suggest. My story continues to evolve as research progresses, and our understanding of consciousness survival deepens. But the central truth remains unchanged. Human consciousness is capable of surviving and adapting under circumstances that should be impossible, demonstrating a resilience and mystery that continues to challenge our most basic assumptions about life, death, and the nature of human awareness.